centimeters. Here they have shown roof, lateral wall, medial wall, floor, layers of the eyeball. So layers again divided into outermost, medial and innermost. So the innermost layer is retina, neurosensory layer, present only posteriorly. Neurosensory layer, present only posteriorly. Middle is uveal tract. Uveal tract is the middle layer, parts anterior and posterior. Anterior uveal tract is iris, ciliary body and choroid and vascular layer. Outermost is anterior 1/6 and posterior 5/6. Outermost anterior 1/6 is cornea, which is transparent, convex shaped, refractive power present. Then the junction is limbus, corneo-scleral junction, and posterior 5/6 is sclera, which is white opaque, covered by conjunctiva, transparent mucous membrane. White opaque, covered by conjunctiva, transparent mucous membrane. Sclera, limbus, iris, pupil seen below cornea. This is the structure anatomy of eyeball. Here at the very end you can see this is retina. Behind the retina is the choroid. In front of the retina is the posterior segment, which contains vitreous fluid, which is 1% hyaluronic acid, gel-like consistency, 1% hyaluronic acid. And outside that you have sclera. Then this is the ciliary body. Ciliary body has two parts. Pars plicata, that it's spleeted, and pars plana, flat, most avascular in uvea. What is the most avascular structure in uvea? Pars plata. This is pars plicata. And then it is connected to the lens. In front of the lens you have your posterior chamber. Behind the lens is the posterior segment, and this is the posterior chamber. And then you have your iris and pupil, and then the anterior chamber. The anterior chamber is covered by cornea, and this is angle of anterior chamber. This is limbus. Anterior chamber between cornea and iris. Anterior segment contains aqueous humor. Posterior segment was containing vitreous humor, and anterior segment is containing aqueous humor. Aqueous humor, fluid secreted from ciliary processes. Aqueous humor is fluid secreted from ciliary processes. Rate of secretion 2.3 microliter per minute. So the ciliary processes are secreting the aqueous fluid. The rate of secretion is 2.3 microliter per minute. Function, it exerts intraocular pressure. What is the function of aqueous fluid? It makes intraocular pressure, and it is measured by tonometry. Aqueous outflow. Aqueous outflow is 0.25 microliter per minute per mmHg. Aqueous outflow is 0.5 microliter per minute per mmHg via angle of anterior chamber. Depth 3 mm, 2.5 mm to 4.4 mm. So aqueous outflow is 0.25 microliter per minute per mmHg via angle of aqueous chamber. Depth is 3 mm, and the range it is in is 2.5 to 4.4 mm is the range of the depth of anterior chamber. It is also measured by tonography. It is measured by tonography. So tonometry is measuring the aqueous fluid pressure, that is the intraocular pressure, and tonography is measuring the depth of the anterior chamber. Anatomy of cornea, sclera and its pathologies. Neurovascular supply of cornea. It is an avascular supply, avascular structure. Cornea is transparent. Refractive power is plus 43 diopter to 48 diopter, converging power. What is the refractive power of cornea? Plus 43 diopter to 48 diopter, converging power. Relative index is 1.376. Relative index is 1.376. Relative index of the cornea is 1.376. Nerve supply. Sensory. Sensory nerve supply is from trigeminal, ophthalmic, nasociliary and then cornea. So the nerve supply of cornea is coming from trigeminal nerve, then ophthalmic nerve and then nasociliary nerve. Corneal blink reflex. Test of corneal sensation. Stimulus. Touch cornea with cotton wisp. Afferent sensory trigeminal nerve, cranial nerve 5, trigeminal nucleus and facial nucleus. So what happens? Corneal blink reflex when you touch it with a brisk of cotton wisp, then afferent sensory trigeminal nerve, then trigeminal nucleus, then facial nucleus, that is the afferent, and then efferent is facial nerve 7, that is the afferent. If that's not working, the efferent pathway, motor pathway, then there is no blinking in Bell's palsy that happens. Inability to close eye is called legophthalmos. Inability to close the eye is called legophthalmos. Effector orbicularis oculi. Effector muscle is orbicularis oculi, which closes the eyelid. No blinking. Reduced or no blinking corneal anesthesia. Response of orbicularis oculi is blinking. But in what cases will there be no blinking? That is corneal anesthesia. The cornea is not feeling anything. So the causes are herpes, keratitis, most common. What should come to your mind when you hear of corneal anesthesia? Herpes, keratitis, most common. Then comes your diabetes, leprosy, acanthamoeba amoeba, keratitis, contact lens wear, surgical trauma, topical medications, for example timolol. So what are the other causes? Diabetes, leprosy, acanthamoeba, keratitis, contact lens wear, surgical trauma, and topical medications, for example timolol. Layers of cornea. So cornea also has layer. Here is a histological image. You can see the starting is from basal layer, which is columnar cells. It can undergo mitosis and regenerate. Middle layer is wing-shaped cells, and superficial layer is squamous cells which have microvilli for addition of tear films. So the basal layer is columnar cells, which differentiates to wing-shaped cells. Middle layer, which differentiates to superficial layer or squamous cells which have microvilli and addition of tear film. Here is another image of layers of cornea. So most metabolically active is endothelium, 5 micrometer, most metabolically active. Then is your decimates membrane. Then is your Duas layer. Duas layer is also the strongest layer. Decimate membrane can regenerate. Then is the thickest layer, stroma. And then is the Bowman's layer, epithelial basement membrane, epithelium which can regenerate. Epithelium can regenerate. So starting from the outside, epithelium basement membrane, Bowman's layer, stroma, Duas layer, decimates membrane, and endothelium. Endothelium is the most metabolically active. Decimate membrane can regenerate. Duas layer is the strongest. Stroma is the thickest. Anterior and outermost layer, epithelium. Histology: non-keratinized, stratified, squamous epithelium. So what kind of epithelium does cornea have? Non-keratinized. So obviously there is no keratinization. It is a stratified. So it actually has multiple layers of cells. And squamous epithelium, that is the top cells are squamous. Note with respect to the center of the eyeball, cornea and retina, outermost layer and innermost layer. Cornea lies anteriorly, retina lies posteriorly. This is like with the center of the eyeball, which is the most outermost and innermost. So we'll just skip this. Bowman's membrane, not a true basement membrane. Bowman's membrane is not a true basement membrane, not stained by PAS, periodic acid skiff reagent. Where was your Bowman's membrane? Here, below the epithelial basement membrane. So why are they not considering it a true basement membrane? Because it's not being stained by PAS, periodic acid skiff reagent. Acellular, cannot regenerate, heals by scar formation, corneal opacity, loss of vision. So here it said can regenerate, so that's wrong. Bowman's membrane cannot regenerate and it will heal by a scar causing vision loss in that area. Corneal opacities. So there are 3 types of corneal opacities: nebular, macular, and leucomatous. Nebular is faint, macular and leucomatous is most dense. Nebular is faint, macular and leucomatous is most dense. Pupillary margin behind opacity, macroscopic. Pupillary margin behind the opacity, macroscopic. So from nebular you can see the pupil visible faintly, macular visible, leucomatous most dense, not visible. So from leucomatous you will not be able to see the pupillary margin. What are the 3 corneal opacities? Nebular, leucomatous, and macular. Iris details behind opacity, microscopic. So only one person is letting you see the iris microscopically, and that is nebular, faint opacity. Nebular or faint opacity. Distribution of visible light. So distribution of visible light, maximum, there is a mild opacity Diffraction, increased distortion of image. Minimum is in leukomatous, dense opacity. Light rays don't cross opacity, increased loss of vision. सो नेब्यूलर में धुंधला धुंधला दिखता है, इसलिए मोर डिस्टॉर्शन ऑफ इमेज हो जाता है, क्योंकि सनरेज लाइट रेज पास हो रही है और वो डिस्पर्शन हो रहा है, उसका डिफ्रैक्शन हो रहा है, जबकि ल्यूकोमेटर्स में वो उसको पास ही नहीं होने देता, सो उसमें लॉस ऑफ विजन आता है. स्ट्रोमा, थिकस्ट कॉर्नियल लेयर जो हमने देखा था, 90% ऑफ कॉर्नियल थिकनेस. कंपोजिशन टाइप 1 कोलेजन फाइबर्स. एक एमसीक्यू में पूछा था कि कौन सा टाइप ऑफ फाइबर्स होता है कॉर्निया में, सो टाइप 1 कोलेजन फाइबर्स. ग्लाइकोअमीनोग्लाइकान्स GAGs. केराटान सल्फेट मोस्ट कॉमन. कौन सा ग्लाइकोजामिनोग्लाइकान्स है, गैग्स. केराटान सल्फेट मोस्ट कॉमन इन स्ट्रोमा. So Duas layer also called pre-Descemet's membrane, मतलब डेसेमेट मेम्ब्रेन के पहले आएगी डुआस लेयर. हम इमेज में भी देखते हैं, जैसे कि ये डेसेमेट्स मेम्ब्रेन है, उसके पहले है डुआस लेयर. पहले मतलब बाहर की साइड, तो डेसेमेट लेयर, डुआस लेयर, प्री डेसेमेट, उसको स्ट्रॉन्गेस्ट लेयर बोला है, बस इतना ही. फिर आता है डेसेमेट्स मेम्ब्रेन. Secreted continuously by underlying endothelial cells, can regenerate. क्योंकि ये जो मेम्ब्रेन है वो सिक्रेटेड हो रही है कंटिन्यूसली बाय अंडरलाइंग एंडोथेलियम, इसीलिए वो दोबारा बन सकती है. Schwalbe's line, peripheral termination at Limbus, near anterior position of trabecular network. Schwalbe's line, peripheral termination Descemet's membrane secreted continuously by underlying endothelial cells so it can regenerate. Schwalbe's line. Peripheral termination at limbus near anterior position of trabecular meshwork. That's your Schwalbe's line. So, peripheral termination of Descemet's membrane at limbus near anterior position of trabecular meshwork. Posterior innermost layer endothelium. Posterior innermost layer endothelium, most metabolically active layer. Endothelium with zona occludens prevents entry of aqueous into cornea. Endothelium with zona occludens prevents entry of aqueous into cornea. So endothelium has zona occludens, so your aqueous does not enter into cornea and it maintains transparency. And endothelium is also the most metabolically active layer. If endothelium is injured or breached, edema of cornea, haze or opacity will develop. Specular microscopy. Findings depending upon cell count. Findings depending upon cell count, specular microscopy. 3000 cells per millimeter squares to 24,000 cells per millimeter square, 500 cells per millimeter square. So they have shown that images, corresponding images. Maximum 3000 cells per millimeter square is normal endothelium. Hexagonal cells, normal borders. Corneal transparency maintained. 2400 cells, then small breach in endothelium. Cornea compensates by polymegathism, increased size. Polymorphism, change in shape. So here you can see 24,000 cells decrease. So between 24 to 500 you are seeing polymegathism. मतलब simply cells are becoming big and they are losing shape. Hexagon से shape बदल गया. So they are still maintaining integrity of tight junctions and corneal transparency is still maintained 24 to 500 में. फिर irregularities and large cavities होने लगी जब 500 से भी कम हो गया. तो irregularity, large cavities, corneal decompensation due to extended contact, lens wearers like hazy cornea. Coming to sclera, outermost covering of posterior 5/6 of eyeball. Anatomy, white due to irregular arrangement of collagen fibers. Why is it white in color? Irregular arrangement of collagen fibers. And it is posterior 5/6 of eyeball. Variable thickness of sclera. So this is cornea, this is limbus, scleral thickness. Posterior to insertion of recti, sclera is thinnest. Around the optic nerve, sclera is thickest. So sclera, limbus thickness, they have mentioned कि लिम्बस की थिकनेस, स्क्लेरल थिकनेस 0.83 mm है और रेक्टाई के पोस्टीरियर टू इंसर्शन ऑफ रेक्टाई स्क्लेरा थिनेस्ट होता है और अराउंड द ऑप्टिक नर्व थिकेस्ट होता है. लेयर्स, एपिस्क्लेरा, स्क्लेरा प्रोप्रिया एंड लैमिना फस्का. एपिस्क्लेरा, स्क्लेरा प्रोप्रिया एंड लैमिना फस्का. सो स्क्लेरा के भी 3 लेयर्स हैं. अंदर वाले का नाम है इनर मोस्ट लैमिना फस्का. फिर स्क्लेरा प्रोपिया मतलब उसका मेन वो ही वास्कुलर है और कोलाजन फाइबर से बना हुआ है. एपिस्क्लेरा आउटर मोस्ट लेयर हाईली वास्कुलर, 2 plexuses, superficial and near sclera proper, and merges with Tenon's capsules around 3 mm posterior to limbus. So episclera outermost layer है, highly vascular, 2 plexuses, superficial and deep, merges with Tenon's capsule around 3 posterior to limbus. 3 mm posterior to limbus. Scleral pathologies. Number 1, scleritis. Number 2, episcleritis. Scleritis is a misnomer, and second is episcleritis. These are scleral pathologies. Scleritis, inflammation of deep vascular plexus of episclera. जो स्क्लेरा के 2 प्लेक्सस थे, सुपरफिशियल एंड डीप, उसमें जो डीप है उसका इन्फ्लेमेशन होता है तो उसको बोलते हैं स्क्लेराइटिस, मतलब मिसनोमर है, एक्चुअली वो वेस्कुलाइटिस होना चाहिए. ब्लूइश वायलेशियस ह्यू इन सीवियर केसेस. सो एकदम ब्लूइश वायलेशियस ह्यू आ जाएगा स्क्लेरा का. फिर आता है एपिस्क्लेराइटिस. इन्फ्लेमेशन ऑफ सुपीरियर वास्कुलर प्लेक्सस कॉजेस इडियोपैथिक, अपने आप से रेडिश ह्यू आएगा, सुपरफिशियल. और ये टेस्ट है वाजोकंस्ट्रिक्टर टेस्ट. प्रिंसिपल फार्मोलॉजिकल रिवर्सल ऑफ इन्फ्लेशन ऑफ इंड्यूस्ड वाजोडाइलेशन. reagent 2.5% phenylephrine eye drops. So 2.5% phenylephrine eye drops डालने हैं तो रेडनेस रिमेन हो जाएगी. तो इन्फ्लेम डीप वेसल्स डू नॉट कंस्ट्रिक्ट टू रिस्पॉन्स. डीप वेसल्स इन्फ्लेम जो है वो नहीं रिस्पॉन्स करेंगे 2.5% एपिनेफ्राइन को. बट यहाँ पे आफ्टर टेस्ट रेडनेस डिसअपियर हो जाएगी ब्लांचिंग से. सुपरफिशियल वेसल्स कंस्ट्रिक्ट हो जाएंगे. मैनेजमेंट सेल्फ रिजॉल्विंग है. एनसेट्स दे सकते हो ड्यू टू पेन. लो डोज स्टेरॉइड्स दे सकते हो. टाइप्स ऑफ स्क्लेराइटिस. स्क्लेराइटिस जो मिसनोमर था उसको फिर से उन लोगों ने जो जहाँ पे डीप वास्कुलर स्ट्रक्चर्स इन्फ्लेम हो रहा था उसको फिर से इन लोग नॉन नेक्रोटाइजिंग और नेक्रोटाइजिंग बोला है. नेक्रोटाइजिंग विद साइंस ऑफ इन्फ्लेमेशन एंड नेक्रोटाइजिंग विदाउट साइंस ऑफ इन्फ्लेमेशन. सो याद रखना है स्क्लेराइटिस नेक्रोटाइजिंग, नॉन नेक्रोटाइजिंग. नॉन नेक्रोटाइजिंग विद साइंस ऑफ इन्फ्लेमेशन एंड विदाउट इन्फ्लेमेशन. विदाउट इन्फ्लेमेशन को बोलते हैं स्क्लेरोमलेशिया परफोरेंस. मोस्ट कॉमन इन वीमेन विथ लॉन्ग स्टैंडर्ड rheumatoid arthritis. Atrophy due to inflammation, only deep bluish vessels is seen. No pain, no congestions. So we'll see this photo. So scleromalacia perforans, atrophy due to inflammation, only deep bluish vessels is seen, no pain, no congestion. So it almost looks like there are 2 pupils in the eye. That is your scleritis. Limbus, corneoscleral junction that contains stem cells. Limbal stem cells, pluripotent cells. Limbus is a corneoscleral junction that contains stem cells. Limbal stem cells is pluripotent cells. Ability to differentiate, for example, into conjunctival, corneal, scleral cells, etc. Universal marker of stem cells is CD34. Specific marker for limbal stem cells is ABCG2. So limbal stem cells are pluripotent cells. They can become conjunctival cells, corneal cells, scleral cells, etc. Universal marker for pluripotent like stem cells is CD34. CD34 यूनिवर्सल, और लिम्बल स्टेम सेल्स का स्पेसिफिक है ABCG2. 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 Site: limbal basal epithelial cells forming palisades of Vogt, elevations and crypts. Limbal basal epithelial cells forming palisades of Vogt, elevations and crypts. Sites of limbal stem cells. So limbal basal epithelial cells forms elevations and crypts, which is called palisades of Vogt. It's a fancy name. Deficiency of limbal stem cells, pterygium, caused by environmental factor. Treatment: excision and autograft with limbal stem cells. So if there is a deficiency of limbal stem cells, then what happens? Pterygium, which is environmental induced. And how do you treat it? Excision and autograft with limbal stem cells. So in the next video, we'll continue with anatomy of uvea, accommodation with its anomalies.